Welcome, dear all, for our fourth episode for Nephropathology lectures on NephroTube. It's our pleasure that we have Dr. Sarah Hassan, Associated Professor of Pathology and Electron Microscopy, Theodore Bilharz Research Institute, Egypt. In this lecture, she will talk about diabetic nephropathy, its histopathology, and differential diagnosis. Please, Dr. Sarah.
السلام عليكم دكتور محمد. I hope you have the benefit of this lecture. And let's start. First, diabetic nephropathy. Diabetic nephropathy is a microvascular complication of diabetes mellitus. And as we all know, it's a gradual progression from microalbuminuria to proteinuria. And usually it takes a decade to start after diabetes. And usually in the typical course of diabetes, usually what happens is that renal biopsy is not done. It's not an indication to have a biopsy for a classic case of diabetes with microalbuminuria. What happens is in the atypical course, we have a renal biopsy, and this atypical course would probably mean that there is another lesion or a superimposed lesion that could be found during the course of diabetes with renal affection. Under light microscope, first I would like to say something. What means that renal biopsy is not done for a classic case of microalbuminuria in diabetes is that the pathology is not seen usually or regularly during our routine work as a nephropathologists. No, we see it frequently, maybe because the patient was not known as being diabetic, was not properly investigated for hemoglobin A1C. Many cases would be the cause that we see this lesion under outlight microscope, but it's not the first indication for a patient with microalbuminuria that is known as a diabetic patient to be biopsized for a renal or be a candidate for a renal biopsy. But we frequently see it with the different scenarios. As I said, being not known as diabetic, or another atypical presentation of increased serum creat or abrupt or marked proteinuria that does not go with his clinical situation. So under light microscope, and let me add another thing. And the most important differential, the most important is to put in your mind the differential diagnosis of this glomerular lesion as being a diabetic nephropathy or something else. So that's the importance of this lecture. It's not just he's a diabetic patient with a renal affection, which could be a common complication for diabetes, but is the superimposed lesions and the differential diagnoses, which are very, very important to put in mind and to exclude in such cases. That's the introduction that I would like all of us to put in mind and to remember why we are discussing this lesion. And I hope it's clear. And if anyone have any question, please don't hesitate to mention it. So under light microscope, the glomerular lesion of diabetes is the glomerular basement membrane thickening, mesangial expansion, or nodular glomerulosclerosis, which is known as Kimmelstein-Wilson nodule. Mesangial expansion is of variable degrees. Yeah, it could be mild or moderate or marked. It could be diffuse or could be nodular. as the nodular Kimmelstein-Wilson nodule, which are usually non-isometric nodules in their size. And with a course upon chronicity, glomerulosclerosis and IFTA, or interstitial fibrosis and tubular atrophy, occurs. So mesangial expansion is Bass stain positive. This is very important to put in mind. The diabetic mesangial expansion is Bass positive. Bass, or periodic acid Schiff stain, is one of the routine stains in nephropathology that we use for all cases. And for diabetic mesangial expansion, we should know that it is Bass positive. This is the first thing to put in mind when we are discussing such cases. Then let's see the glomerular basement membrane that we have mentioned in the first lecture, that it should be thin, just like as being drawn by a sharpened pencil. A sharpened pencil will draw the normal glomerular basement membrane. But here it is thick, a little bit thick, as well as the Bowman capsule is thick, and the tubular basement membrane as well. Here is the mesangium. The mesangium is expanded mainly matrix expansion with low cellularity. The tubular basement membrane will also be thickened, and the nodules here appears, which are also Bass positive, and the nodules are non-isometric. So this is a small nodule, and this is another one, but is larger in size, and both are hypocellular with no cellularity or minimal cellularity. And I would like just to mention that mesangial hypercellularity is not always specific. It could be non-specific. So you may see here some cells, and this does not exclude this as being mainly an expansion of the matrix, because the matrix is simply, or the mesangial matrix is simply made by mesangial cells, so they may be more or less more cellular, but classic speaking, it is a low cellular or hypocellular nodule. Another histopathologic character is the capsular drop or the hyaline deposition here, which cause the Bowman capsule to appear like that. And another, that's upon chronicity, the glomerular sclerosis. These glomeruli are sclerotic, and all the surrounding tubules are atrophic with variable degrees of atrophy. So that's IFTA, which will occur upon chronicity. Another lesion, which is characteristic, very characteristic for diabetic nephrosclerosis, that we should put in mind at the second point to put in mind. The first one was the Bass positivity of the nodules or the mesangial expansion. The second one is the hyaline arteriosclerosis, which involves both, and we should put in mind both the afferent and efferent arterioles. That's characteristic for diabetic affection of the glomeruli, unlike hypertensive nephropathy, which causes afferent arteriole hyalinosis only afferent arteriole, not both the afferent and efferent arterioles. And this slide will compare between the normal arteriole, is the afferent arteriole, the normal, versus the arterioral hyalinosis, which by chance this cut shows us the afferent and efferent arteriole, and both are hyalinozed. That's hyalinosis. Compare between the wall of this arteriole from the normal one. It's a little bit thick and pinkish colored, and that's the hyalinosis. We can see also here the mesangial expansion with the nodular formation, hypocellular nodular formation. If we compare it with the normal, inconspicuous, as we have said in the first lecture, or that is not seen it's nearly not seen here. Where's the messenger matrix? It's inconspicuous. We cannot see it. But here it's expanded and cause nodular formation. Okay, what about immunohistochemistry or immunofluorescence for diabetic nephrosclerosis? Is it an immune complex mediated disease? No, it's not an immune complex mediated disease. It's a non-immune complex mediated disease. So, is it negative? It is negative under immunohistochemistry. No, it could be positive by linear deposition for IgG, but it's not a specific deposition. It's non-immune complex disease. It's just the deposition of IgG as a part of the glomerular hyperfiltration. The main pathology or pathogenesis of diabetic nephrosclerosis is the glomerular hyperfiltration. The glomeruli are overloaded. So with the hyperfiltration, with the blood hyperfiltration, the glomeruli have an entrapment of plasma proteins, and immunoglobulins are part of these plasma proteins, so they may be deposited along the glomerular and tubular basement membrane and causes linear deposition. What differentiates between the non-specific or just an entrapment of IgG along the glomerular basement membrane from other immune complex mediated disease is that these IgGs does not cause complement activation. So no C3 or complement factor 3 deposits. It's just the entrapment of IgG. Under electron microscope, the electron microscope is just a reflection of what we see under the light microscope. So if we have seen thickening of the glomerular basement membrane under light microscope, under electron microscope, we will see diffuse thickening of the glomerular basement membrane. The same for the messenger expansion, the same for podocyte affection, which is secondary to the thickening of the glomerular basement membrane. So we'll see effacement of podocytes, but what emphasizes on that this is a non-immune complex mediated disorder is that there is no electron dense deposits under electron microscope. As we have said, it's just an IgG entrapment that will appear with immunohistochemistry or immunofluorescence, mostly with immunofluorescence, not under immunohistochemistry, the technique of work of the immunostainings. What is more or an add-on for electron microscopy in these cases is that sometimes, and that I have faced in some cases, it's not an uncommon for the light microscope to be to show us no change under light microscope, and by electron microscope we see diffuse thickening of the glomerular basement membrane more than the normal range for age and sex. That was to be proved later on that this patient has an early or pre-diabetic state by hemoglobin A1C or other investigations. This patient is in a pre-diabetic state with microalbuminuria with no change under light microscope, but electron microscope shows an early change, which is diffuse thickening of the glomerular basement membrane. And that's the difference between this membrane with its diffuse thickening when we compare it with the normal thickness of this membrane. The overlying podocytes are diffusely effaced, while here these podocytes are normal. The differential diagnosis. First differential diagnosis is the hypertensive nephrosclerosis with the similar or near similar pathogenesis of the hyperfiltration or the glomerular hyperfiltration. And as we have said, the hyalinosis here is only or mainly in afferent arterioles. The second for the arteries shows arteriosclerosis with elastosis with hypertension. And this picture for an artery this is the elastic lamina of the artery with a thickening of the intima this intima is thickened. And if we track this elastic lamina here, we will find that here it's a multi-layered. It's the single layer, it's another layer. So this is elastosis, or more than a single layer of elastic lamina that occurs with hypertension. With time, the glomeruli with hypertensive nephrosclerosis could be ischemic with shrunken tufts with periglomerular fibrosis, and it's not a non-specific finding. It could occur as an end stage for many glomerular pathologies, non-nodular glomerulosclerosis, of course, and the glomerular basement membrane here could be thickened as well, but irregular thickening and maybe wrinkling as a part of the ischemia in the glomeruli, and will be less prominent as this glomerulus if we compare it with the first glomerulus that we have seen for diabetic changes. And you can compare, this is smaller shrunken glomerulus. The glomerular basement membrane is more or less thick and is more shrunken, the periglomerular fibrosis, rather than thickened Bowman capsule. So this is a shrunken and ischemic tuft. Another two shrunken tufts with more expansion in the Bowman space, secondary to these ischemic tufts with periglomerular fibrosis. The second differential diagnosis is amyloidosis. Amyloidosis is a very important differential diagnosis because first, let's start with the BOS stain, or the periodic acid shift stain that we have mentioned in diabetes as being positive stain in the thickened mesangium and glomerular basement membrane. Unlike this, amyloidosis is BOS negative or weakly positive. The BOS stain gives us the pinkish color, as we have seen in the BOS slides. So it will be either BOS negative or lightly pink when compared to the diabetic glomerulosclerosis. Unlike diabetic nephropathy, amyloidosis is what? Is an extracellular deposition of a fibrillary deposits. It's not an expansion of the already present mesangial matrix. No, it's an extracellular deposition of something. The amyloid fibrils with its pathogenesis. It's not our topic today to discuss the pathogenesis of amyloidosis, but generally speaking, amyloidosis is an extracellular deposit, while diabetic nephrosclerosis is an expansion of the already present mesangial matrix, and maybe that's why we can explain the BOS positivity. The mesangium matrix, the normal mesangial matrix, is BOS positive by itself, while the fibrillary matrix from outside, it's not BOS positive, it's BOS negative. So that's how we could explain why this is BOS negative and that's BOS positive. Amyloid deposits could be in any of the renal cortical compartments, in the glomeruli, in the tubular interstitium, or in the vessels. Let's check the mesangium here. Can anyone tell me about the mesangium? Can anyone describe it? No answers? Nothing is written in the chat box. دكتور محمد حد جاوب؟
Yes.
Any answers?
They say that it is normal cellular.
Normal cellular? The mesangium is normal
Atrophic.
cellular?
We have another answer, which is atrophic.
Okay, any other ideas? Okay, let me explain about the mesangium. That's the mesangial area. This mesangial area is expanded. It's not normal, it's expanded, and it's hypocellular, no cells, and it is fluffy. Fluffy, it's like a cotton. Okay. It looks expanded and fibrillary. So it's fibrillary or fluffy. Here, it's also expanded, but more aggressive expansion. Sometimes we can, this could be like a trick because it could be not easy to detect it. But with more experience and as you see, you will know that that's not normal. It's expanded, it's more fluffy. That's expanded, more expanded. It causes some nodularity here. What about this area? And what about this arteriole? I think that the fibrillary or the fluffy texture of this expansion of the arteriolar membrane is more appreciated in this slide. And it's just like this expansion. Can you appreciate it?
Yes, it is clear.
Oh, okay. So again, for a Bose stain, this staining is lighter than this one if we convert it. Okay, so this is lighter than this, and that's what I mean when I was explaining the weak Bose positivity or the Bose negativity of the amyloid deposits. So unlike diabetic nephropathy, amyloidosis is in extracellular fibrillary deposits, as we have seen, and Congo-red as we have said, it's Bose negative, but Congo-red positive. Congo-red is another routine stain in nephropathology, and amyloidosis is the famous Congo-red positive deposit. Amyloidosis is a famous Congo-red positive deposit and Bose negative deposit that gives the apple green birefringence under polarized light. So with Congo-red, this will be the positivity, but this is not enough. This is not enough. This brownish color is not enough to say that that's amyloid. We should see it under polarized light and see this type of polarization, this color of polarization, which is called the apple green polarization, this color. Okay, with immunohistochemistry. What about immunohistochemistry? What is the role of immunohistochemistry in diagnosing amyloidosis? The immunohistochemistry or immunofluorescence for amyloidosis, it is used for immunophenotyping and not for diagnosis. For immunophenotyping, which means what is the cause or what is this amyloid is of which type. Is it amyloid A at this case? So this case, the antibody for amyloid A was positive, or it could be monoclonal. Amyloidosis could be monoclonal for kappa or lambda lighted chain, and in this case, this will be a AL amyloid, which mostly lambda positive. So that's the role of immunohistochemistry or immunofluorescence in amyloidosis. Why didn't I mention electron microscopy in the cases of amyloidosis? Of course, amyloidosis is under electron microscope, has a characteristic feature of the fibrillary deposits with a certain diameter to be measured, but actually electron microscope is not a diagnostic tool for amyloidosis. Amyloid is diagnosed mainly by its BAS negativity and its Congo-red positivity, and its immunophenotyping by immunohistochemistry is very important. And later with next slides, we'll see what else could be fibrillary under electron microscope. The third differential diagnosis is membranous nephropathy that could be differentiated morphologically, or why it is one of the differential diagnoses, because it causes thickening under thickening of the glomerular basement membrane. But with in this case, it's an immune complex mediated disorder that causes subepithelial deposits with what is known as spikes that will be formed along these deposits, with the formation of the glomerular basement membrane along these deposits. Let's compare between diabetic nephrosclerosis, again with its thick glomerular basement membrane. This thickening is just as smooth as we see here, but here the thickening of the glomerular basement membrane is with these like hair-like or spikes along the outer surface of the glomerular basement membrane, which are made by what? By a glomerular basement membrane reaction along the deposited material causing these spikes. So it's an immune complex mediated disease with IgG again, but this time IgG deposit will be granular, and C3 here will be positive, unlike diabetic nephrosclerosis, and the rest of the panel will be negative. And that's the shape of the granular appearance of this. That's an immunohistochemistry and not immunofluorescence. Immunohistochemistry that is done on the paraffin block sections, and granular deposits of IgG and C3 appears like that. And that's the electron microscope, and these are the subepithelial deposits. So that's the lumen of the glomerular capillary, and here is the outside with the podocytes. These are podocytes. What are these? These the electron dense, which means that they are more black when compared with this matrix of the glomerular basement membrane. They are deposited subepithelial, and here they are entrapped within reaction of the glomerular basement membrane around them, that will appear under light microscope with silver stain and sometimes with Mason trichrome stain as their spikes. Okay, then next differential diagnosis, and is a very important differential diagnosis and a very dangerous one that should be excluded, is the light chain deposition disease. And it's challenging. Why? Because it mimics diabetic nephropathy. It mimics it, as it will be BAS positive as well. Immunohistochemistry or immunofluorescence is the main differential diagnosis between both, for the monoclonality of the deposition with kappa or lambda restriction or predominance. And let's discuss. That's the monoclonal lambda light chain deposition disease along what? Along the tubular basement membrane. This was for a real case with actually the glomeruli were mostly globally sclerosed, and the patent ones were shrunken, and its tubular basement membrane were thick with light chain caused nephropathy affection. This patient presented with proteinuria, mainly with proteinuria, heavy range proteinuria, which was not mainly albuminuria. It was heavy range proteinuria, which is classic for light chain cases or monoclonal deposition disease and cause nephropathy, to be a hyperfiltration of the light chains. So the proteinuria will be not mainly of albumin, but it will be mainly of the monoclonal proteins. And under EM, we will see the classic powdery appearance, subendothelial, and along the outer surface of the tubular basement membrane. So it will be subendothelial along the inner surface of the glomerular basement membrane and along the outer surface of the tubular basement membrane in cases of light chain deposition disease. And they will be powdery, not fibrillary as amyloidosis. They will be powdery like that. Let's explain the difference, or try to explain the difference between diabetic nodular glomerulosclerosis and the dangerous monoclonal immunoglobulin deposition diseases, where the patient could have an underlying monoclonal gammopathy, or even multiple myeloma, and his first presentation is renal affection with just proteinuria, and these cases may regress clinically, both for the his hematological disorder and his renal affection as well, by targeting his monoclonal disease, and it's not a primarily glomerular disease and will be life-saving. So let's try to diagnose these cases. For mesangial morphology, both will be the same, both positive for diabetes and for MIDDs. The tubules in these cases are very important, and could be misleading. The tubular basement membrane is thick in both, and IFTA, or interstitial fibrosis, and tubular atrophy may be present in both, and this does not exclude or diagnose one of them. So let's see what we can see in MIDDs. The tubular basement membrane could be thick, and it will be more refractile, more under light microscope, it will be more refractile for MIDDs. And we should put in mind that MIDD could occur together with light chain cast nephropathy in the same biopsy, and this is very common to see both, because the underlying cause is one disease, which is monoclonal gammopathy. So this will, as the case that we have seen, it's slide for tubular basement membrane light chain predominance, lambda light chain predominant. This case was just like that, was codominant MIDD plus light chain cast nephropathy, and even in some patients the tubular affection may predominate with minimal or ischemic glomerular affection. So the glomeruli may goes faster towards the chronicity, and you may miss the nodular sclerosis, and miss the glomerular basement membrane thickening, but light chain deposition along the tubular basement membrane with light chain cast nephropathy will be the sign or the clue to diagnose these cases. So just look carefully in the tubules in these cases with marked ischemic glomerular affection, but there's something like cast nephropathy in the tubules. So in these cases, the immunofluorescence or immunohistochemistry is very important, and it's very important to look along the tubular basement membrane for the deposition of the monoclonal IgGs, and not in the lumen of the tubules, but along its membrane, along the tubular basement membrane for the monoclonal restriction. Another clue is the number of nodules. It will be more multiple in the same glomerulus in MIDDs, while tends to be more solitary in diabetic nodular glomerulosclerosis. But as we have said, immuno is very important, and it's very important to look carefully along the tubular basement membrane for monoclonal restriction, even if the glomeruli are not does not give us specific findings or a specific restriction. For EM, as we have said, the monoclonal deposition has a powdery like deposits. And just let's read these sentences. That classic picture is, as mentioned, occasionally these classic deposits in a known patient of monoclonality fail to stain for kappa or lambda immunohistochemistry antibodies. Perhaps this could be due to altered antigenicity not detected by commercial antibodies, and possibly monoclonal heavy chain deposition is a case. So immunohistochemistry is important, as we have said, but it could, sometimes it could be misleading. Why? If it is negative or it does not give a predominance for one of the two light chains. Why? Because perhaps it could be a monoclonal heavy chain, as we all know that the immunoglobulin has one heavy chain and two light chains. Not always the monoclonality occurs for the light chains. It could occur in the heavy chain, and usually what is usually used in commercially in our labs is the monoclonal light chains. So if it is negative, but under electron microscope we see the powdery appearance, and this patient was investigated and proved to be of an underlying MIDD, it could be a heavy chain. It's a monoclonal heavy chain, or could be it's just an monoclonal antibodies that could be truncated or have many alterations or another mutations that was not detected by the commercial antibody. And in these cases, EM is important in diagnosis. Okay. I hope these points were clear. I tried to clarify it as much as I can, because these cases sometimes are challenging and difficult and very important to diagnose. Membranoproliferative glomerulonephritis is another differential diagnosis. Because why? Because it causes mesangial expansion and glomerular basement membrane thickening. But in this case, mesangial expansion will be with hypercellularity, and glomerular basement membrane thickening will be with double contouring. It's not just a thickening with for secondary to deposition of the glomerular basement membrane material, but it is double contouring, and we will discuss why the glomeruli will be double contour. Of course, with endocapillary hypercellularity, and electron microscope will show deposits under subendothelial or mesangial, and could be even subepithelial. So MBGN could be an immune complex mediated disease, or usually is an immune complex mediated disease, and let's consider it here as an immune complex deposition disease, because other pathologies may end up with the MBGN pattern of injury without immune complex depositions, like the chronic TMA. But let's consider it here, the MBGN, the famous MBGN of infection-related glomerulonephritis or lupus nephritis is an MBGN pattern of injury in cases of class 3 or class 4 with mesangial expansion hypercellularity, endocapillary hypercellularity, glomerular basement membrane thickening with double contouring. So it's an immune complex mediated disorder with granular deposits of IgG. Of course, C3 will be positive, and the rest of the panel will be plus or minus according to the case. Okay, so that's an case of MBGN with thickening of the glomerular basement membrane, mesangial expansion with more cells, and endocapillary hypercellularity here. Mesangial hypercellularity is more clear here, and with both stain, the double contouring is seen, more mesangial hypercellularity, and here is the inflammatory cell in the lumen of the glomerular capillary, another neutrophil here, endothelial injury, as we have discussed in the second lecture, with ballooned cells, and these are the immune complex deposits, another immune complex deposits here are intramembranous with new basement membrane formation, another deposit here that if we compare with the matrix, it will be seen as a darker, another immune complex deposit in the hinge region of the reflection of the glomerular basement membrane along the mesangium, but in more in the mesangial matrix. So that's this picture. We see immune complex deposition disease. This is a new basement membrane material that it is laid on. And finally, double contouring occurs, as this picture shows us, with the main glomerular basement membrane and the second one with an interposed, that's the cytoplasm of probably a mesangial cytoplasm that is interposed between these two membranes. Maybe this occurs as we have seen here. This is a endothelial cytoplasm with arborization here in these defects that were formed secondary to the laid down immune complexes, with this interposition that will progress later on, and later on will be more and more till we have this double contouring that will be seen under light and electron microscope. Other differential diagnoses that will cause also a glomerular basement membrane thickening is the dense deposit disease. Under light microscope, it may mimic any pattern of MBGN, mesangial pattern, or even post-infectious GN. And this is commonly seen more in children with immunofluorescence that reveals C3 only or predominant. We can see some IgG deposits, but dense deposit disease is an electron microscopic diagnosis. It is not diagnosed except by EM. With this electron dense transformation of the tubular basement membrane. What's meant by transformation is the glomerular basement membrane is transformed into this continuous, and sometimes it's not that continuous. It could be like sausage shaped deposits, which are of C3 deposits mainly. What is else fibrillary? As we have said in the previous slides, we have mentioned that amyloidosis is a fibrillary deposit. What's else fibrillary? Fibrillary GN is another fibrillary deposit with variable appearance under light microscope, but commonly with mesangial expansion due to an infiltrating of an extracellular fibrillary material as well. It is Congo-Red negative, and that's the first differential diagnosis from amyloidosis. The position is of usually polyclonal IgG, so it's in IgG, it's an immune complex mediated GN with polyclonal IgG and C3 under immunofluorescence or immunohistochemistry. So that's another differential diagnosis from amyloidosis. Amyloidosis was just immunohistochemistry was used for its immunophenotyping, for its known subtypes, but fibrillary GN is an immune complex mediated GN it's a polyclonal. By EM, we will see fibrils with haphazard arrangement, and their measurement will be from 12 to 24 nanometers in diameter and not in length, in diameter. And currently, DNA GP9 is the specific marker for this disease. And these are the fibrillary deposits that we can see both in amyloidosis and in fibrillary GN, but there's the difference between both, as we have said in their description. These are the fibrils, and we have, unfortunately, to measure the diameter of these fibrils to differentiate between amyloidosis and fibrillary GN. That's why I see that the differentiation with the special stains, the Congo red stain, and immunohistochemistry is much more easier, and I think much more accurate than diagnosing, than measuring these thin fibrils. Cryoglobulinemic GN is caused by intracapillary and capillary wall or subendothelial deposits of cryoglobulin deposits, giving mainly a membranoproliferative pattern of injury. These patients usually have purpuric eruptions with arthralgias, secondary to vasculitis affecting their skin. Abnormal serologic studies include the known or the famous known low C4 in 3/4 of these cases, and sometimes a low C3. It has 3 types, including those due to monoclonal and polyclonal. Some types are mono, or another types are polyclonal. Can cause cryoglobulinemic GN, although most commonly it occurs in setting of type 2 or mixed cryoglobulinemia, which is secondary to the HCV infection. Most patients of 2 or 3 will have a serologic positive rheumatoid factor. These cryoglobulins are known to be refractile plugs, intracapillary plugs, that are what? They are BAS, strongly BAS positive. The arterioles could have these deposits as well. By immuno, we will see IgM and C3 and usually monoclonal light chain deposits. By EM, they will be characteristically formed of another fibrillary deposits, but these fibrils will be wormy and more thick. Let's see this case. It was for an HCV patient with these refractile, and that's what we mean by refractile. It's clean and subendothelial deposits with very well formed inner and outer surface of this arteriole. And another deposit here is the mesenchymal here. When we compare with the normal, let's compare with the normal of this membrane versus this membrane versus the previously seen hyalinosis. That's very different from hyalinosis. I hope if anybody will revise this lecture, put in mind the difference between this refractile cryoglobulin deposits from the previous hyaline deposits. These are the cryoplugs. These are the cryoplugs. This BAS stain, and these plugs are BAS positive. Under electron microscope, these are the plugs, and here the subendothelial deposits that will appear like worms. Under electron microscope with a higher magnification, so they are thicker than the fibrillary GN and the myeloid deposits. Another deposits which will we can describe them as being fibrils or tubular with microtubular substructure, as we described under electron microscope. This patient do not have cryoglobulins in their serum, but they have a circulating monoclonal paraproteins as well, or lymphoplasmacytic malignancy. As we have said, that the remission or the outcome of this disease is related to achieving remission with therapy that's directed against the malignancy, and this rarely lead to end-stage kidney disease. Under EM, they will be well-defined, long microtubular deposits, so they are thicker than the fibrils, and often in parallel arrays without detected cryoglobulins, as we have said, and they will be more typically IgG versus the cryoglobulins that are more typically IgM. Immunotactoid GN under electron microscope, though they are more parallel. Fibronectin glomerulopathy, which is rare, I didn't see it before. It's post positive, but Congo red negative. Under electron microscope, we will see granular or fibrillary structures with 12 to 16 nanometer diameter fibrils, and it's diagnosed with immunohistochemistry against fibronectin. So the conclusion is that diabetic nephropathy show characteristic lesions, as we have said. Histopathology combined with the clinical context is essential, and differential diagnosis is critical, especially in nodular glomerulosclerosis. And thank you.
Thank you, dear Sarah, for this very informative lecture. I think you covered all the differential diagnoses for diabetic nephropathy in details. We have very few questions in the chat box. Actually, it is a question in amyloidosis. Are the deposits mainly lambda? Is it right?
Of course, no. As you have mentioned, we should do an immunophenotyping
Yes.
for amyloidosis. It could be an AA, it could be a light chain deposits according to the immunophenotyping.
Yes.
It's not always monoclonal.
Yes.
Could be like
in membranous nephropathy
or other types that we do not have a commercial antibody for.
Yes, yes. If there is the classic membranous shape with diabetic patients with the spikes in the pathology, would we treat these cases with steroids, or we consider it membranous nephropathy second to diabetes, and we should only control the glycated hemoglobin level of the patient? What do you think? Is it that common? Is it that common that you can find in the biopsy result the classic membranous nephropathy shape or not?
For a diabetic patient?
Yes.
I think I don't know, because this patient may have diabetes.
Yes, it is not common actually.
Oh, I didn't see it before, but
yes.
I didn't see to see what I have seen for in diabetes. It could be post-infectious GN.
Yes.
Because this patient has his immunity is not that well. Yes. In diabetes, as I have said, that it was common to discover that he's diabetic in his renal biopsy. And most of the cases is the differential diagnosis. The differential diagnosis, especially for MIDDs, is a very important one.
Yes, there is another
but
question.
Membranous.
Yes.
Membranous, in a case of diabetes, he will be presenting with his membranous nephropathy, not with his diabetic affection.
I agree. Yes.
So it will be classic membranous.
Okay, can you give a stepwise approach for diagnosis of nodular glomerulosclerosis? I think from the pathological point of view.
Stepwise, how to diagnose diabetic nephrosclerosis in a renal biopsy?
I think you covered this point
first,
already.
I think first post stain, then Congo red stain, and these are the first steps. It's post positive and Congo red positive or negative, then the immuno, and yeah, that was the main topic for the lecture.
Okay. Another question: if you have a diabetic patient with nephrotic range proteinuria, and we did a biopsy, do you routinely do a kappa and lambda chain staining or not?
He's diabetic with nephrotic range of proteinuria.
And we did a biopsy.
Okay, his biopsy.
Do you routinely stain for kappa and lambda chains?
I think we should do it.
Yes,
routinely.
I think too.
I think yes, you should do it routinely, whatever the presentation, whatever he's diabetic or not, whatever his age. even in 30s, because he could have an underlying monoclonal thing, and presents even with focal segmental glomerulosclerosis. And that we have seen in some of our patients.
Okay, thank you, Sarah. That was the last question. Thank you again for this great lecture. And see you next
Thank you.
month, inshallah, in
Inshallah.
a new lecture, بإذن الله.
Inshallah.
Good night. Bye.
Nice.